All right. Well, listen, we'll go ahead and get started, kicking off the AMSSM Ultrasound Case Series presentations for the attending physicians for the next 6 months. And so I have the pleasure to introduce Dr. Mitchell Daugherty. Dr. Daugherty is a graduate of the Ohio State University Primary Sports Medicine Fellowship, and he currently practices full-time with the Beacon Bone and Joint Specialist in South Bend, Indiana, and also with his time as a faculty member of the Notre Dame Primary Care Sports Medicine Fellowship. And today he's going to be giving us a presentation on Pes Anserine Bursitis.
Well, thanks for having me. Again, my name is Dr. Daugherty, and I'm going to give a discussion on a recent case of Pes Anserine Bursitis I saw a couple months ago. And so we'll just go ahead and get started. I have nothing to disclose for today's presentation. And so starting out with the case, it was an unfortunate case of a 22-year-old international collegiate athlete that we had locally, presented for evaluation of medial knee pain. And he had a pretty long-standing history of left-sided leg injuries that he had been dealing with. He had a past medical history of a left tibia and fibula shaft fracture that he sustained in 2021 back at home that was repaired, but unfortunately complicated by non-union. I first saw the patient back in 22 with complaints of persistent leg pain and diagnosed with non-union at that time. Complex treatment course. He went back home for treatments and continued to suffer from non-union until more recent union here in 2024 and 2025. Was finally achieved union of his tibia after intermedullary rod placement and autograft repair here in town in 24. And this was his most recent x-ray. So poor guy at 22 had been through a lot. But the presentation to our clinic evolved when his lower leg was feeling better, but he had persistent medial-sided knee pain that was aggravated with resisted knee flexion and with local tenderness to palpation at the Pes Anserine complex. And so orthopedic surgery then referred him to the sports med clinic for further evaluation and treatment, including potential injection of the Pes if indicated. And so today we're going to talk about ultrasound evaluation of the medial aspect of the knee. And then we're also going to take a look at some adjacent structures more towards the anterior, as well as going back to the posterior aspect of the knee. But the main structures that we're going to evaluate for the medial knee include the MCL, and with MCL evaluation, including valgus stress if indicated. We're going to talk about the medial meniscus and evaluating that throughout the tibial-femoral joint space. Specifically, we'll focus in on the Pes Anserine tendons and the bursa as well. And I'll demonstrate both normal anatomy and then the abnormal anatomy we saw with this particular patient. And then looking at the medial patellar retinaculum and the patellofemoral joint as well along that medial recess, and then going more into the anterior aspect of the joint and that suprapatellar recess. And so in addition to the evaluation today, we're going to talk a little bit about some of the anterior knee structures as well, including the quadricep patellar tendon, patella itself, and the associated bursa, as well as the hyaline cartilage of the knee, and then dive a little bit into some of the posterior medial structures, such as evaluation for Baker's cyst and taking a look at the posterior medial tendons, such as the semimembranosus and the mediogastrocnemius. And so starting out at the medial aspect of the knee, just talking about general ultrasound setup. For the knee, typically you're going to be using a linear probe. For this case today, I'm using an L15-4 probe. For most knee structures, you'll be able to evaluate these diagnostically with a linear probe. Occasionally, you'll use a curvilinear probe depending on the size and body habitus of your patient with posterior knee structures. But in most of these cases, you'll be able to see everything that you need to see with that linear probe. In talking about diagnostic ultrasound and initial setup, especially when I'm working with our fellows, I talk about first finding your bony landmarks when you're trying to identify your anatomy. Soft tissue can vary widely between patients, especially when evaluating normal versus abnormal pathology, but bony landmarks stay relatively same between patients. And so finding your landmarks, kind of finding your home base with those bony landmarks are key to getting everything set up and evaluating these other soft tissue structures. And so starting out looking at the MCL on this particular patient, you'll note that I'm pointing out the right MCL on this case, and the previous x-ray that I showed was the left knee. Here I'm going to show normal anatomy, and towards the end of the case, I'll go back and show the left MCL and the Pes Anserine complex as well. But starting out on the right knee, we're looking at images of the proximal MCL. We start out in the coronal plane and identify the MCL attaching at the medial femoral condyle and extending distally down to the proximal tibia. The MCL is going to be composed of two different layers. The superficial layer is the tibial collateral ligament. And then as we get down to the meniscus, we'll see the deeper layers of the MCL, which are composed of the meniscofemoral and the meniscotibial ligaments that typically you can delineate when ultrasounding these areas. You want to evaluate the MCL both in long axis and short axis as well. And so on the right side of the screen, I've got a short axis view of the MCL. It's a rather broad ligament. Literature cites its average width about 15 millimeters. And on this image, that checks out. If we take our ruler on the side of the screen here and extrapolate it over, the width of the MCL is about 15 millimeters here. And so you want to look at both the long and short axis because of the width of the ligament. Sometimes you can get tears or pathology at the anterior aspect of the ligament that if you're just looking at the coronal view and focused on the posterior aspect of the ligament, you may miss, some pathology there. And so I want to make sure that you're looking at both of these structures in both long and short axis. Specifically, if there's been any prior history to the knee or persistent pain at the proximal MCL, you may be also looking for any proximal calcification that can be indicative of a previous MCL trauma. We refer to those calcifications as Pellegrini steta lesions. And so that's something to evaluate for in these long and short axis views at the proximal MCL. Scanning more distally, we get over the tibiofemoral space and start to see the medial meniscus here. Again, I talked about the superficial and the deep components of the MCL. And so on the superficial aspect of the MCL, we see the tibial collateral ligament extending from proximal to distal. And then below that, we can see delineation between the superficial and deep fibers. And so we've got our more proximal meniscofemoral ligament and then our more distal meniscotibial ligament here. And so we're able to delineate between those. And then as we travel more distal down to the proximal tibia, we see the extension of that tibial collateral ligament down, inserting on to the tibia. And then we start to see some of our Pes Anserinus here at this area as well. In evaluating the MCL, you may also be doing dynamic stress testing as indicated. And so if they had a valgus stress to the knee or any evidence of laxity of the MCL on your physical exam, you can quantify that or grade MCL injury with ultrasound criteria. And so this is typically graded 1 to 3. Your grade 1 injuries will show normal fibular pattern and normal structure of the MCL, but may show surrounding anechoic or hypoechoic fluid. When you apply a valgus stress to the knee, if you measure the distance between the femur and the tibia, and then measure it again after applying a valgus stress, if you've got less than 5 millimeters of widening, that can also be an indication of a grade 1 injury. Grade 2, you start to see disruption of the normal fibrillar pattern and normal structure of the MCL. You may see some hypoechogenic areas in addition to surrounding edema, but you won't see complete disruption at this point in a grade 2 injury. And then if you're doing a valgus stress, you may see 5 to 10 millimeters of widening of that tibiofemoral joint space. And then a grade 3 ligament injury is going to be when you have complete disruption of those MCL fibers. And then if you're doing a valgus stress, typically greater than 10 millimeters of widening is indicative of a grade 3 injury. And then I've got a video just looking at the coronal plane, scanning from proximal to distal of the MCL, just showing how long and how far the ligament extends. And again, we start to get into the Pes Anserine complex that we'll bring up on the subsequent slides here. So going into the Pes Anserinus, again, this is looking at the right knee, wanting to point out normal anatomy before I get to the abnormal pathology. And so your Pes Anserinus is going to be a group of 3 tendons that pass over the distal MCL to insert on the tibia. And these include your sartorius, your gracilis, and your semitendinosus tendons. The Pes Anserinus is Latin for goosefoot. And so if you can imagine a goose foot, it's composed of 3 toes kind of spread out in a web. And that's the similar appearance of these tendons as they insert on the tibia. They fan out across the MCL, inserting on the tibia. And so here we're again in the long axis view, and we start to see these tendons coming across the deeper tibial collateral ligament. And this is going to be the area where you're looking for any bursal fluid. Typically, you're not going to see any evidence of fluid in these cases. Rarely do we see true bursal inflammation in these areas, but if it is present, you'll typically see it between the Pes Anserinus and the underlying tibial collateral ligament. You can also look at the tendons in long axis with a sagittal oblique view. And so on this view here, this is the medial aspect of the knee, and this is more lateral, where we can see the course of these tendons with that normal fibular pattern and then inserting on the tibia. And so if you go into that sagittal oblique view, then you can identify and pick up those individual tendons. Again, with the bursal distension not normally seen, it can be more prevalent in patients with type 2 diabetes or rheumatoid arthritis, but again, not often a common appearance that we see when evaluating the Pes Anserinus. Looking at the medial meniscus, and again, the medial tibiofemoral joint space, the meniscus is going to be this triangular structure present within that joint space. The apex of the meniscus can be more difficult to evaluate just because it's deeper within the joint, and you can't see it as clearly because of shadowing from the bone. And so we're going to see more of the periphery of the meniscus a little bit better. With ultrasound, it can be a good tool to rule in meniscal pathology, but because you get incomplete evaluation of the meniscus, if you're not seeing any abnormality on the meniscus, it doesn't necessarily rule out any pathology. But ultrasound can be reliable in detecting peripheral tears of the meniscus. You can see a hypoechogenic cleft through the meniscus. Sometimes you can see areas of hypoechogenicity within the meniscus, which may indicate degeneration versus tearing. You can identify parameniscal cysts with ultrasound. And so these are all different things that you're looking at, scanning at the medial aspect of the knee. And so you'll follow the meniscus from the anterior horn out here coronally to the body underneath the MCL. And then you can follow it to the posterior horn at the posterior aspect of the knee as well. Again, depending on your patient, the size of the patient, sometimes to get good visualization of that posterior horn of the medial meniscus, you may need to use a curvilinear probe. But again, a lot of times you can get away with that linear probe to evaluate for these. In older patients with underlying osteoarthritis, you can also identify extrusion of a medial meniscus relative to the tibia. And so many times you'll see decreased joint space between the femur and the tibia, and that meniscus will be pushed out of the joint. And so those are things that you can evaluate for as well with ultrasound. Specific to the medial aspect of the knee and the posterior medial joint, you have to be cautious of the semimembranosus tendon inserting. You can get some anisotropic artifact at that area that could look like a parameniscal cyst. But you can correct your ultrasound probe positioning to bring that into better view. And then going to the medial patellar retinaculum, this is going to extend from your patella to the adductor tubercle of the femur. This is a thin band of fibrous tissue that includes the medial patellofemoral ligament. Here on the screen, we're looking at the patella here on the left side of the screen, and then the femur here on the right, with this thin band of fibrous tissue coming down and inserting. At this area, you can also look at the medial joint recess and sometimes identify evidence of effusion present in this area. In this evaluation, typically you want the knee in full extension to identify fluid within that recess, because as you start to go into flexion, it will typically push it out of that recess if you've only got a small effusion. Larger effusions may still distend that area, but more mild or trace effusions, you may only pick up with the knee in full extension. Scanning more towards the posterior aspect of the knee. Again, starting out identifying bony landmarks. Here on the left side of the screen, I'm identifying the posterior medial femoral condyle. And so you're going to see the bony cortex here with a hyaline cartilage cap. And so that's a good bony landmark to find, your home base at the posterior aspect of the knee. And here we're looking at the knee in short axis. What I'm demonstrating here on the posterior medial aspect of the knee is the medial gastroc here at this area. And then more medial to that is the semimembranosus tendon. And so this area is important to evaluate because this is where you're going to identify Baker's cyst if present, which you'll see fluid extending underneath the medial gastroc, and then that fluid gets pushed through the medial gastroc and the semimembranosus, which acts as a one-way valve, and then you will often get collection of bursal fluid present here as a result. And so this is the anatomy that you'll be looking for at the posterior medial knee in evaluating for a Baker's cyst. The next slide, I've got a video looking at probe positioning. You want to be careful in evaluating these areas because depending on how you're holding your probe, either the medial gastroc or the semimembranosus can look anisotropic and lead to potentially false diagnosis of a Baker's cyst when it's just an anisotropic artifact. And then if you scan more towards the popliteal fossa, medial femoral condyle, lateral femoral condyle, you'll get your more vascular structures, which tend to be more lateral, and you can identify these with color Doppler. And so this video is kind of demonstrating as I toggle the probe from cranial to caudal, you can get different appearance of the medial gastroc and the semimembranosus, which depending on how you're positioning your probe, you want to make sure that you're not mistaking a hypoechoic area for a Baker's cyst when it's just anisotropy. Going to the anterior aspect of the knee, here we're looking at the quadricep tendon, your patellar tendon. You've got your suprapatellar or quadriceps fat pad, your prefemoral fat pad, and your femur. This is the area where you're also going to identify any evidence of effusion. There's some trace fluid here within the joint, which can be physiologic, but you're looking for any large effusion that may track up underneath the quadricep tendon. Typically, simple synovial fluid will be anechoic in appearance. And so any hypoechoic, isoechoic compared to the surrounding, fatty tissue can be an indication of complex fluid within the knee. Or if you're seeing that it's not compressible and you're getting Doppler flow in this area, you may be looking at some synovial hypertrophy. But this is the typical long axis image that you'll get of that suprapatellar recess. If you're trying to identify the joint space, sometimes some quadricep contraction or increased knee flexion can pull some of that fluid up further into that recess. And so here the patient's doing a slight quadricep contraction, which can better delineate that joint space there. And that's especially helpful if you're doing any interventions such as aspiration or injection, especially injection in somebody that doesn't have much of an effusion at all. At the anterior aspect of the knee, you can also assess the hyaline cartilage, both of the femoral trochlea, as well as more anteriorly in the parasagittal plane, you can look at the hyaline cartilage of the femoral condyles. And so here is a short axis view of that femoral trochlear cartilage. You can identify osteochondral defects in these areas, You can look for calcific deposition, such as with pseudogout or sometimes gout crystals on the chondral surface. And so these are various things that can be diagnosed and identified with diagnostic ultrasound. Looking specifically at the quadricep tendon, your quadricep is going to be made up of 4 different muscles. On the short axis view here, more proximal within the thigh, we've got your rectus femoris, your vastus medialis, lateralis, and intermedius. And as you track that more distally, you'll see those come together as the quadricep tendon, with the vastus medialis muscle being the one that extends furthest distal compared to the other surrounding muscles. Specifically, when ultrasounding the quadricep tendon, typically you want the knee in about 20 to 30 degrees of flexion, which pulls a little tension on the quadricep. If you're in full extension, you'll get more of a concave appearance of the quadricep, which can lead to anisotropic artifact and potentially missed or false diagnoses of tendinosis or tendon injury. You'll want to look at it both in long and short axis. The quadricep tendon is made up of the 3 different layers. Your superficial layer is typically your rectus femoris. Your middle layer comes together from your vastus medialis and lateralis, and then the deep layer is your intermedius. And so with ultrasound, you can, by understanding those different tissue layers, you can help diagnose partial quadricep tendon tears versus full thickness tears. Specific to full thickness tears, you may see complete disruption of the tendon. You can see joint fluid that tracks superficial to the tendon. And so those are different pathology that you're looking for in that case. Scanning more distally to the patella, you can scan the patellar cortex, looking for any cortical defects that may suggest underlying fracture, especially if there's point tenderness there with sonopalpation. This is where you'll also evaluate your prepatella bursa, which you want to make sure that you're not putting pressure on to distend any trace bursal fluid. So in this case, we're floating the probe across some ultrasound gel to make sure that we're not getting that compression there. When evaluating for a cortical defect in the patella, be aware of your bipartite and tripartite anatomic variants. Again, those are going to be more smooth edges of the cortex as opposed to irregular edges in a fracture. And typically you're not going to have tenderness to palpation at those areas in those anatomic variants. Scanning down to the patellar tendon, again, your normal linear fibular structure, similar to the quadricep tendon, attaching at the inferior pole of the patella and down at the tibial tubercle. In these areas, you also identify your infrapatellar bursa, which there's a superficial, which is anterior to the patellar tendon, and then a deep infrapatellar bursa between the distal patellar tendon and the tibial cortex. Some trace fluid within that deep infrapatellar bursa is considered physiologic. And so in this case, we see some trace fluid here, but that is normal. And then looking at the patellar tendon in short axis, you're able to evaluate the full width of the tendon. You see some of your medial patellar retinaculum coming off of here. I lose some of that here on that lateral side, just from the probe floating off of the knee here. And then again, evaluating tendons, be wary of anisotropy. I'm toggling the probe cranial to caudal here. Depending on the positioning of your probe, you'll be able to bring that tendon into good view versus more of that hypoechoic appearance of the tendon. So getting to back to the case of the athlete that I presented initially, this is his long axis view of the MCL and the Pes Anserine complex, and we can see compared to the initial evaluation, a significant abnormality at the Pes Anserinus. Here we see one of our tendons, but then a lot of hypoechogenicity and evidence of swelling or bursitis present in this area. And then as I scan medial to lateral across these areas, also see additional abnormalities within that complex. So as I scan more lateral from this bursa, I start to see this very hyperechoic structure with deep shadowing present in this area, both in long axis and then short axis view again. And so again, going back to the initial case, this patient had underlying orthopedic hardware. And what we're looking at on the ultrasound here is a proximal interlock screw protruding from the tibial cortex that then is putting mass effect and mechanical irritation on the Pes, which was likely contributing to his symptoms. And so that's another tool or feature that you can use diagnostic ultrasound for. We'll often use it in identifying hardware abnormalities causing persistent pain for patients. So routinely we'll see like distal radius fractures with persistent, tendon pain, or ankle fractures where you've got screws or other hardware causing mechanical irritation. And so rather than doing any injection for this patient, referred him back to orthopedic surgery. They removed the screw, and fortunately his symptoms have resolved since that time. And so here's a video kind of demonstrating that proximal screw again on ultrasound. And so going into my ultrasound report, again, we did a diagnostic ultrasound of the left knee. I include the referring provider when one of my orthopedic colleagues sends these patients to me. Our indication for the ultrasound was persistent medial knee pain with tenderness at the Pes Anserinus, and his pain was replicated with resisted hamstring activation. And so, all of our findings that we discussed today were normal with the exception of the Pes Anserinus. And so we talk about the extensor mechanism, including the quadricep, patella, and patellar tendon were all normal. There was no evidence of quadricep or patellar tendon injury or tendinosis. There was no evidence of prepatellar or infrapatellar bursitis. There was trace anechoic fluid present within the suprapatellar recess that is felt to be physiologic. There was no evidence of synovial hypertrophy or trochlear cartilage abnormalities. The medial collateral ligament was normal and without evidence of injury. The medial meniscus showed no apparent evidence of injury within the limitations of ultrasound visualization. There was no evidence of Baker's cyst or other posterior medial ganglion cyst. The Pes Anserinus was abnormal and showed evidence of tendon thickening and associated bursitis. The proximal interlock screw of the tibial intramedullary rod was noted to be protruding from the tibial cortex and in direct contact with the Pes Anserine tendons. And so our impression from these findings today is Pes Anserine tendinopathy and associated bursitis felt to be secondary to direct contact and mechanical irritation from that proximal interlock screw. And so with that, any questions with this case or ultrasound evaluation of the medial aspect of the knee?
All right. Well, thank you so much, Mitchell, for that thorough presentation. I guess I'll just kind of open up just with a few comments, about the case, and we'll kind of open it up to any further questions that anyone has that you can also put in the chat box. Yeah, for these Pes Anserine, cases, receive a decent amount of referrals for ultrasound evaluation of this and potential interventions. I'd say the majority of cases, it's one of these that end up not seeing always a ton of bursal distension, for a lot of patients. I will say the two subset of patients and pathology that I actually truly have seen bursal distension have been, as shown in your case with patients that have had hardware, at that area, especially if they've had an ORIF where they have some type of, mechanical irritation as you demonstrated. The other cases are going to be sometimes in patients with underlying connective tissue disorders, especially something like Ehlers-Danlos. And in those patients, I have seen occasionally, snapping of the Pes tendons as well, too, that will truly create like a Pes Anserine bursal distension at that area. As far as then, differential for these cases, you went through a very, thorough protocol. I think the two areas that I really try to interrogate the most along that medial knee as far as differential, for sure would be then that medial meniscus, especially for, younger patients if they're going to have a perimeniscal cyst, at that area, which sometimes can obviously distend distally, over to that area. The other would be then the semimembranosus tendon, as well too, which is going to be a little bit proximal to those Pes tendons, especially for endurance athletes. You can get a lot of tendinosis bursitis and even get bursal distension, at that area. So for sure, as far as the protocol, those are kind of the two main areas that I also try to focus on as far as pathology. So, but those are kind of major comments I wanted to bring up. But if anyone else has any questions, here to start.
Yeah, this is Doug Hoffman. I guess as usual, I have a couple comments. Mitch, first of all, those are beautiful images. I mean, those are really great to look at, in a great case.
Thank you.
Yeah, just throwing out because a lot of new people tend to watch these, in terms of annotation. And typically, what I teach is we should annotate to the level where someone familiar with ultrasound would recognize images. And I could recognize all of those images. I think most people who do that recognize clearly the long and short axis of your images. But I also would throw out just add in long and short axis. So, you had the side, the structure. And so people just getting started in ultrasound can make that decision how much they want to annotate or not annotate. A little picky thing, but again, a lot of people just getting started with ultrasound watch these and I throw that out. Again, beautiful images of the Pes. You know, couple ultrasound views that I find really helpful. And one of those is your long axis view of the distal MCL. And there's three layers there, and it's easy to pick out those three layers. So the superficial layers you mentioned is the Pes tendons, kind of in an oblique view, short axis to oblique view. You have the distal MCL, and then you have the inferior medial geniculate neurovascular bundle. So I find that kind of a useful image to get oriented and even find the Pes tendons. Also, finding the pes tendons, if you're more posteriorly and you want to follow them more proximal to distally, it tends to be posterior medial. So going from lateral to medial, you're going to see the semitendinosus gracilis and sartorius, but the sartorius is the lowest muscle. And so if you see three tendons and you see muscle or skin slightly proximally, the sartorius is always going to be the lowest muscle. Um, I kind of, Stephen, what you were saying is we get a fair amount of referrals for these, and my experience is that oftentimes when people are referred for question pes anserine tendinosis or bursopathy, um, I don't see it. And the two most common I see are people who have had a knee arthroplasty and those with osteoarthrosis. And there was a interesting article that came out saying that this is underdiagnosed with people with osteoarthrosis. And that hasn't been my experience. I kind of throw that out to anybody else on what's their experience because I mean, rarely do I see an actual, Pes Anserine abnormality. The couple I've seen, are similar to Mitch's. They're often associated with hardware. I've seen one associated with a knee arthroplasty. But I rarely see an actual abnormality of the Pes Anserine tendons or bursa when referred. So I'd be interested to know what other people's experience is.
Yeah, Doug, I would just fully reiterate that, like 100%, that very rarely do I see it. In those cases, it is one area that I will say that some subset of patients can get adipose tissue and soft tissue swelling at. And so I think sometimes that sets off the appearance that it could be bursal distension at that area, which is why, sometimes get a decent amount of referrals, for those patients. In this scenario, I still, will do diagnostic injections, for the PES, at this area, even if I don't see a lot of bursal distension, just to kind of rule it out, for these patients, especially if there is other underlying, pathology that they're still questioning. But I would 100% agree that I very rarely will see any type of true bursitis in this area.
I see Brennan Ryan, you're on. Do you have a similar experience?
Hey Doug, this is Brennan. Yeah, this is a great case. I think my findings would echo what you guys have both said. The other so hardware is the number one reason I see actually abnormalities here. The second, I've seen a couple of patients with RA that will get like a true Pes bursitis, but almost all of the ones where it's knee pain, and they know swelling is exactly what Steven said. There's oftentimes a fatty deposit there that people are 100% convinced has to be a food collection because someone told them that, and that's always a little bit of a challenging conversation to have that it's not abnormal and it's just how they are. But most of my OA referrals have no discernible abnormality there.
Speaking of that, enlarged fat pad, this is kind of in the we see it category, but there is an article or two on it where there's just subcutaneous fat hypertrophy. In other words, the layer is thicker, and medial elbow, volar forearm, and medial knee would be, and a medial ankle would be the most common areas I see, where you just basically see a normal subcutaneous adipose tissue, but it's thicker than the contralateral side. And I agree, I've seen a few cases right over the Pes.
All right. Well, unless we have any other questions or comments, that will conclude today's presentation. And then we'll plan on meeting in a month for the next presentation. So thank you again, Mitchell, for this.
No, thanks for having me. I appreciate it.